because you couldn't give EECC at the basic places, maybe at your diagnostic level. Maybe the patient came for the CT scan, then you didn't provide oxygen, went to hypoxia. You take the patient to ICU. The patient will not be affordable, will not be able to afford the cost and the treatment you delay, and the patient will lose, and then we lose the patient. So if you see the big part, Sehemu are achieving essential emergency and critical care, which is providing oxygen, putting intravenous fluid, triage, and monitoring. If you say EECC, this is EECC. You triage your patient. When you get into the hospital in the morning, you should know who is more sick, who is less sick. Don't take them as a group. We have 7 patients. No. We have 7 patients, but 2, they are serious. Triage, yeah? If you do that, you'll be able to offer treatment according to the priorities. So just to put oxygen, to give intravenous fluid, and to do monitoring, how much does it cost? Very little money, right? Hapa ni umeme tu na mkuwepo, si ndio? Maybe cannula and all that. But if you go to intermediate emergency and critical care, you need a CPAP, for example. CPAP machine oversuppressor. How much is noradrenaline? It's expensive, right? And then you put in a pump. Maybe 10 noradrenaline you finish, maybe in 2 days like this. How much that patient is going to use for the whole week to stay? And if you not keep monitoring and capture and treat the patient properly, we'll go to advanced emergency and critical care. That's ICU. Then you need maybe something like a ventilator, mechanical ventilation. That is worse. Because even if you put an event, you need to be there. Because the tube can block, the vent can switch off, and a lot of alarms. So you can see the big part of saving life is in when you are giving a very simple intervention. But what is happening in real situation? Nurse is chatting. Blood pressure of the patient 140/8 millimeter of mercury. Good. The patient came maybe from cesarean section. After some time, she will chat again. Blood pressure of the patient 120/76. Then she will give a report. Go home. The other one will come. Blood pressure of the patient 80/50. Does not know that this blood pressure is going down to compare with the first one so that you intervene. So when you say monitoring, it's not to look at the monitoring document. It is to look at the monitor, interpret the results, and intervene. That is monitoring. And this is where we are missing. This doesn't need money. Need you to be conscious, well trained, and know the role of your role in emergency, essential emergency. Your role as an anesthetist in order to avoid other complications. Just do a monitoring. If someone is doing a proper monitoring, we'll either call, shout for help, or we'll give something, maybe fluids or anything, maybe blood or something. Then the patient condition will remain the same situation, will not go to the need of ICU. Do you understand? Fluid administration. Go and do research. Me, I've done it in my medical life. If you go to a patient, you find an empty fluid connected to a giving set with a needle on top. Common practice. You like it, you dislike it. Start looking at your fellows, if not yourself. If you go to the ward, every bed you find a drip is empty with a needle on top connected to a patient with a dirty cannula plaster. Means this person doesn't know EECC because we don't, of course, we don't give fluid because it has finished. We give because with indication. But if no indication, they remove the bottle because you are living there. That you are living there in sepsis. Niye kajaribuni kitu kile usimwambie mtu ingia ulini pale angalia kwanza kitanda cha kwanza cha mwisho unakuta matripo na nini yameisha. Why? Because they are giving medication. They put paracetamol and they will never come to look when it's finished or not. They will come back again to put the other paracetamol metronidazole at night shift. So we are missing here in EECC. So our aim is to know this basic thing and to prove that it is cost effective. Uwekezaji mkubwa sana umefanyika, a lot of money put in TB program, HIV program, maybe obstetric, mother and child. Maybe me and my fellow guys will never be pregnant. But this cut across to all, even adult, woman, man, pediatric, old man. If you don't do ECC, is going to die. I think this is the first place we need to put effort, to put training, skills, and that small little amount that is needed to improve the life of these people. So you have, sorry, again, the slide is too small, I'll share them with you. You have to make a policy for you to be able to implement ECC. Of course, you need money, but also you need trained people. But all of them, you sit down and make a policy, like treatment protocols. I will show you the next one. It's called vital signs-based treatment. Then you have to get a flow of equipment. You need to have equipment. But not only equipment, maintain them. People that spoke today about biomedical engineer, that's very true. A ventilator of 40 million, a patient mount of 15 million, someone is just pulling it with the SPO2 probe down. While your phone of 300,000, you put a protector up and down. Because it's not yours. Maybe that ventilator is your house. Okay? So we need to have equipment. If you don't have equipment, you cannot do it. Go up the time, mount out and everything. But apart from that, we have consumables, chain of supply. This is another problem. You know, you have 10 syringes, and you wait until it becomes 0. That's when you say, I don't have syringes. You cannot provide EECC. EECC, you need a full crash cut, full equipment. You use adrenaline, you replace before the patient comes. You use ET tube, you replace it. So that if you need to do any resuscitation, just pull the crash cut and start using it. So if you don't have good chain of supply of consumables, you cannot do ECC. And this is a very big problem, especially in primary health care. Because labda kwa sababu mkuu wa wilaya anaumwa pressure, the hospital watanua dawa za pressure za gharama, lakini Succinylcholine ni shilingi 3,000 utafuta. Kwa twende tuwashauri hapa availability of consumables for ECC. Staffing, infrastructure, and training. We have spoken today about shortage of staff. If you don't increase number of staffs, it's still a problem of monitoring. Standard ICU, 1 patient, 1 nurse. In other countries, in Tanzania, 2 patient, 1 nurse. In anesthesia, 1 patient, 2 anesthetists. Sindio? 1 patient, 2 anesthetists, because they are conscious, not talking everything. But in the world, 1 nurse, 20 patients. So your facility is trying to increase number of surgeries so that you get money and 10 surgeons to operate. And you don't think about post-operative care. That nurse, you find night shift, she's like crazy. She's running all rooms. Anaweka drip huko, akitoka huko katoa kanyoka. Akirudi huko kajisaidia. You see? Then you come in the morning, then you ask, how many deaths? What happened? Tell us, right? You know? The same number of nurses you are putting during midday, maybe it should be the same number of nurses you put in during night shift, if you want to do good monitoring. Unless otherwise, they will go to hypotension, all patients, and your leg down will be 0. You have done a very big surgery. We did at Mugabe, we did VPOS procedure, 11 hours. 11 years boy was a twin. A brother donated blood, family donated blood. You know, if you give blood, they will not give you the same blood. You just donate to compensate if they take another blood. So Friday we ordered the patient to give blood. Resident came, wrote the patient, we are writing the file. Nurse didn't give blood. On Sunday the boy died. But there Before there was an intern and a student. All in charges, they are sleeping on the weekend. You can't find any in charge in night shift. Can't you do ordering at night? Why you should not go to night shift to supervise your fellows? In charge what wanaingia asubuhi hadi saa 9, including in charge wa anesthesia. Ukiingia saa 12 jioni hadi asubuhi, wewe ukafanya ordering za 4 usiku, asubuhi tukatoka. Sio? Okay, weekend, holidays. It's a problem in monitoring. So you need to be all generator, you can improve critical care services. So this is just designed for how to improve the essential medical care. Efforts required to introduce EECC. It's very difficult, but if you have it, you will enjoy. You have very few patients in ICU, very few complications, just by training a nurse how to shout when blood pressure goes down. Again, a small slide, but you can see the red and green and yellow colors. This explains danger, abnormal and normal. Red is danger. If you have danger, you need to intervene. This is called vital sign directed therapy protocol. Walteneza Muhimbili National Hospital, they introduced this in 2014, VSDT. So you see a vital sign, you intervene. You see the vital sign, you report it abnormal. So they look at the brain, that is Glasgow Coma Scale, the lungs, airway and breathing, and the cardiac, ABC, the blood pressure and the heart rate. So there's abnormal low, abnormal high. For example, blood pressure less than 90, that is danger. Blood pressure more than 110, maybe diastolic, that is danger. Or systolic more than 160 is danger. Nurse is reporting danger, and the doctor should prescribe something. It's very easy. Then again, heart rate maybe less than 40 or 50, danger in adults. And the opposite is to heart rate more than 110 is danger. And abnormal and normal. So you put your vital signs in that way: danger, normal, abnormal. For Glasgow Coma Scale, 3 to 8, danger. Maybe for respiratory rates less than 8, danger, like that. Then you do intervention. It's very easy. ABC approach. If it's A the problem, then again, airway management. So you lift your thrust, oxygenation. B, maybe supportive ventilation. C, maybe some fluids, or vasopressor. A patient is dying, and the patient who is monitoring the patient doesn't know what the meaning of shock index. Heart rate of more than 120 in adult, even in anesthesia. You find someone gave anesthesia to a patient, and the heart rate is maybe 140, and someone is listening to music. Every day I used to tell people, if you have high heart rate, you have myocardial injury. High heart rate, myocardial injury. Because the coronary circulation happens during diastole. So when the heart pumps blood, blood goes to other organs. When it relaxes, it gives blood to itself. So if you increase the heart rate, you bypass coronary circulation, you get myocardial injury. Okay. Okay, I'm told you time is almost. Advantage of health system to have EECC, even in your hospital, is low cost. If you increase number of staff and you have good equipment, functional, good supplies, you have you lose money, but maybe little compared to have one patient in ICU. So there is a station now. Later. When you calculate the amount, you find that you have used everything in a draw. No patient group will be left behind because you will do for all patients triage, vital treatment. Increase preparedness and readiness. So if in case of any emergency, you guys are already prepared because you have everything in place. Improve care and outcomes of critical care, of course. Also reduce hospital stay. Optimize impact of scaling up oxygen use, capitalizing and protecting the huge recent investment made by government. Serikali imenunua ventilator nyingi sana, lakini hatuzitumii. Ilipotokea crisis ya moto Morogoro 2018 I think, very small. We don't monitor a patient, but we want to take them to ICU. But we need to be like this. ECC should do much compared to. And when it comes a small problem, maybe pandemic, COVID, imekuja, or anything, floods, motor, the health system will fall down, or hospital, because you didn't have a good route for ECC. We need to be like this. Very little in upper and more in lower. Operationalizing ECC resources for poor setting is just to ensure readiness and resilience, to be ready to adapt. You call it adaptive changes. First thing is behavior and attitude. To practice ECC, need you to be committed. Daktari anafika ofisini, akifika anapitiza moja kuchukua fomu ya bima. Au muuguzi anaandikiwa dawa, kutoka hapa ndio anakunywa chai. Kutoka hapa anasema mgongo unauma, naomba zile paracetamol zangu. Sasa wewe umefika, anaondoka. Kidogo anadiscuss na mzee kuhusu vikoba, finka pale, wamekopa nini, basi siku imeisha. Commitment and to be readiness to adapt. Develop and implement of stepwise how to make it up. Rapid assessment tools to identify gaps. Vifaa vinavyo na kutengeneza tool ya ku-identify hizo gaps. Kwa mfano, kuna shortage ya staff. That's the gap. How will you know there is a shortage? You have a standard benchmark, you compare. Emergency box and trolley to be filled with drugs. Unakuta una cash card kubwa na dawa hata moja. Standard routine and checklist for triage. To have checklists for using training, focus on essential skills. To official to the cannulas, to intubate, kuweka LMA, oxygenate, and all those things. Procurement. The data needs and develop research agendas. Thank you.
Asante sana Dr. Benz kwa wasilisho. Naamini kila mtu akiweza kulifanyia kazi vizuri, tutakuwa na msingi mzuri wa afya, kwa sababu afya zote zinaanza kwenye primary health care. So thank you so much. Sawa, Angel, karibu. Tutunze maswali yetu, kama tutakuwa na maswali tutauliza baadaye. Tumechoka, tujinyoshe kidogo wakati anakuja. Tusimame wote. Haya, tuweze kunyosha mikono yetu juu namna hii. Twende kushoto, twende kulia, nyuma, mbele kidogo, halafu tukae. Asante sana. Chezea msosi wewe. Chana na msosi. Sana, karibu Angel. Hawa ni wenzetu anesthetic officers. Walisoma huko nje, tuungane nao atupe na wenyewe madoso ya huko nje. Elimu zilizopanda ndani. Karibu sana.
Asante sana na wasalimu wote. Good afternoon. It's my great pleasure to stand before you all kwa sababu I know we all have the same agenda. Kuja hapa is not by mistake, and I'm very proud that tuko wote hapa. So bila kupoteza muda, allow me to start. Nitakuwa nafanya pitching ama tutasemezana juu ya digital transformation in anesthesia, particularly advancing patient safety through AI and innovation. We have to know that in the today's world, the technology is running quite fast. And not only that, but also the today's world, we are all speaking about technology. And technology transformation is not only in some industry, even health industry, we are affected by the technology. So allow me to say that I respect you all, and also I greet you all. Before I say anything, allow me to call everyone to have an imagination. Have you ever thought if a patient cannot speak? Oh yes, it's during surgery. A patient is not responsible for anything about his or her safety, but rather you have to know the system that are built around the other ones that are. Mgonjwa hawezi kusema ndugu yake hayupo. Je, ni nani atakayemsemea? Let me take you through a brief African reality. It's believed that less than 1% anesthesias per 100,000 population. Just as the former speaker said one thing, that we are in a world where the health technicians are less than the population that they are being treated. Did you imagine, in case if it's only 1 or 2 anesthesists inside a hospital and there are more than 10 patients per day? You can just have that picture in your mind. In the African society and in African realities, there is a higher surgical mortality rate. Not only that, also there is a limited access to safe surgery. We should not speak of Africa. Let's speak of our own country, Tanzania. Yes, we love Tanzania, but what is happening in our own country? Number one, most paper-based preoperative documentation, and I really love what the former speaker spoke. He said that there was a young man, an 11-year-old, who died, but why did the child die? Just have a question. Because of the poor documentation. It was paper documentation. And yet, no person suspected, what if they were using AI to say that the child was never given blood? There was no any blood transfusion to the child throughout the days that he was hospitalized. But on the paper, it's well documented, and it says that it's given. Just imagine it's your own relative. A person dies because of poor documentation. That's horrible, and that's what's happening in Tanzania. We have to know we have fragmented theaters, ICUs, and recovery room. There are places that they're just there. There are rooms in the hospital that they're just written ICU or yes, recovery room, but there are no enough practitioners to deal with the room. We have delayed clinical decision making, and also patient safety risks due to missing data. There is where we need AI or any digital transformation is a necessity for anesthesia. We need to understand that the core problem is not a big deal actually. We have little problems that we are facing, like late detection of complications, limited monitoring system, and also workforce shortage. The previous speakers also, the TANPA president represented this thing about workforce shortage. One thing we have to understand, we do not have workforce shortage. There are millions, there are hundreds of graduates outside there. But yet, we are on the street, no one recognizes us. Yet we are being told, because only we are not having a board, then could it be our effect having a board? No. Then let us ask ourselves, when we are complaining of workforce shortage, what could be the solution? Because you can't say we have workforce shortage while we are hundreds of graduates from abroad, different countries, India, China, Turkey, and other more. But yet, we come to Tanzania, they say they do not recognize us. That's so sad. That's very sad. We cannot complain that we have a problem of workforce shortage while there are people who can handle it, and yet we are on the streets. we need to know what is digital transformation in anesthesia. Yes, it's either integration of artificial intelligence, digital monitoring system, electronic health records, and telemedicine. All these companies, they are all working to make anesthesia safe, smarter, and more patient-centered. Unaweza jiuliza kwa nini tunasema digital transformation kwenye anesthesia? Lazima tujue ya kwamba kazi moja tu ya digital transformation, tunahitaji anesthesia ambayo itakuwa very smart. Lakini tu so smart, the aim is safer. Kwa sababu we are not doing anesthesia for our own sake. We are doing anesthesia for the betterment of the patient. As you see this diagram, it's just a simple diagram and it's explaining about digital transformation of usage of AI, smart monitoring, electronic health records, and also telemedicine. I want to say that in case AI could be used in places like preoperative care, predicting high-risk pattern could be easier. Our former speaker was speaking about EECC. If we could use AI in ECC, it could be quite easier to predict a high-risk pattern. You will not just be going blindly. There are procedures like intubation. It's a blind procedure. But yet, we just do it blindly. What if we had AI, we could know that before anything happens, a certain risk could be predicted. But also we could identify complications earlier. Any complication could be detected. And also we could improve the planning system for our patients. Allow me to say that AI in intraoperative care, it's also a help. It could be used for early detection of instability. Also, real-time alerts. At times we are in theater rooms, yes. We are in ICU rooms, yes. But one thing, we are not alerted. Sometimes we are busy, as what the previous speaker said. There are people in the theater, they're busy listening to music. That's not fair. Sometimes when alerts are beeping and bumping out, no one cares about the alarms. What if we could be having a real-time alert that this time the pressure is low, this time we need to do this thing, this time the fluid is out, so you need to increase the other one. What if becomes the question. And also precision drug delivery. You know, in anesthesia we are dealing with drugs too much, and that's the reality. But the question comes, at times you are told, we just need 2 mils, but you find a person putting 2.2, 2.1, 2.3. We are human beings, I understand. We cannot be so precise, but we can do it. So, allow me to say that AI can also help out on how to do it. Also AI in post-operative care. After surgery is done, there are complications that arises, but if AI can be used, it can predict those complications, but also it can optimize pain control. Not only that, it can reduce ICU admissions. What the former speaker said, he said that ICU is quite expensive according to the chart and the graph that he showed. Yes, what if we could be caring our patients and also we could reduce the ICU admissions? It could be a benefit also for our patients to reduce every cost that is unnecessary. There are things that are done that are quite unnecessary, and that could be done. I want to say that we have patient impact. There are things like personalized care, reduced complication, improved outcomes. Before I proceed, allow me to ask, what's the theme of our year 2026 today? I am speaking to everybody. Kindly answer. What's the year for our today's? Safe anesthesia? I didn't hear it. Well, we can do more and we can do better. Safe anesthesia? Thank you so much. If we're saying safe anesthesia, safe surgery, then here's where it comes with patient impact. If it's safe anesthesia, there is a personalized care. If it's a safe anesthesia, there are reduced complications. But also, if it's a safe anesthesia, it has improved outcomes. Therefore, we'll be saying safe anesthesia, safe surgery. So we have to understand that we have a part to do, and we can do more. Without wasting time, allow me to say that there is a research to outcome models. When we do research, protocols are followed, but also practice are followed, and hence it gives us an outcome. What research are we doing as an anesthetist? What research are you doing in your hospital? Or you just see things are not working well, and yet you're kind of okay. Are you following the protocols as how the former speaker explained? Because if you follow the protocols, if you do a good practice, then the outcomes becomes quite good. Not only good, but impactful to the patient. There are several opportunities for Tanzania when I speak of digital transformation in anesthesia. We have to know that it's a wake-up call for Tanzania to invest in digital system. Training healthcare workforce. We have been complaining of shortage of workforce and everything, but do we train them? Naamini kuna watu ambao wametokea sehemu mbalimbali. Kuna mtu ambaye nilikuwa naongea naye hapo nje akasema ametokea Songwe. Personally, I don't know Songwe. Sijui Songwe iko wapi, lakini najua ipo Tanzania. Ila the question comes, mnapokaa huko vijijini, huko maeneo ndani ambapo serikali labda inatambua yes kuna shida. You guys, kuna any training inaendelea? Labda tuulizane. Hamna, that's the thing. Sasa kama hamna training, how are you working? And I just need to find a logic answer. Mnafanyaje kazi kama there is a less training? Yani what happens? I'm trying also to think out loud. Labda tusaidiane. Naona kila mtu anafurahi. Naamini kuna watu wana majibu. Nisaidie mtoto wawili tu. Mniambie hilo jibu. Yani nitafurahi kwa sababu kuna maeneo vijijini. Mimi nimezaliwa Arusha, nimekulia Arusha. At least Arusha it's a good city and it's growing up. Sasa kuna vijiji ambavyo binafsi sijawahi viona. Sasa nikijiuliza mambo yanaendaje huko. Kwa mfano yule ambaye tumeambiwa akapanda mtungi kaika pikipiki, I was like, oh my God, how is everything happening in that kind of place?
Things are happening good and God is helping us.
Thank you so much. Thank you so much. Thank you for the answer, Kawalibia. That's great. Yaani kwa nini nimeuliza, we need to know ya kwamba we need training for healthcare workforce. Sio tu huku mjini, usisikie tu ya kwamba only Muhimbili people are being trained, only KISAYANSI, only Buganda. Twendeni hata huko na vijijini. It's a necessity. Na sio tu kufanya hizi training za kawaida. We need also on the digital part. Pia tunahitaji ya kwamba kujua opportunities kama expanding teleanesthesia. Tukisema teleanesthesia, we mean more modern anesthesia. And why more modern anesthesia? Kwa sababu we are going to a modern world. Unaweza kusema hapana ndugu yangu, kwa sababu kule kijijini kuna watu wajua hata kutumia kiswasado. Kiswasado is that bad and fun. Sasa you can be asking kwa nini you are even opting for the modern and the digital thing. The world is transforming and also people need to transform. We should never stay on our own comfort zone because time is evolving. We have to know kuna few challenges, infrastructure gaps, funding limitation, and training needs. Lakini the challenges should never limit us. We have a call to action. Lazima tujue digital transformation is a necessity. Yani digital transformation is not an option, it's a necessity. Sehemu ambapo dunia inaenda na inapoelekea, it's quite far. Yani we are moving with technology. Najua wazazi wangu hapa, watu wengi ni wakubwa zangu na wengine ni wazazi wangu, wanasema kwamba teknolojia inaharibu, but let me tell you, technology is not destroying. Technology is there making things out wisely and greatly. So let me have a question for you. Ya kwamba we should never be questioning ya kwamba whether we can adapt UE or digital transformation, is it possible? But the question that we need to keep in mind is, are we willingly to act? Are we willingly to adapt the digital transformation? Lazima tujue ya kwamba we have to move from intentions to implementation starting today. Huku nikiwa nikimalizia kabisa, naomba kujua kwamba we have knowledge, yes. We have technology, yes. What remains is the decision to act. Hata wale kule vijijini, you guys, you got knowledge, you got technology. The issue only remains to act. Lazima tujue kwamba the difference in anesthesia sio the complicity ama ya anesthesia ama ya mazingira, but it's the timing. Wengine hapa tumeshasema tunatokea kule vijijini ndani, yani I'm so inspired na nitafika usiku nyingi ya kwamba issue sio ile mazingira, but the issue comes ya kwamba the timing of you making a decision, that could be the most important thing, to save a life or to lose a life. As I'm finishing, allow me to say ya kwamba we need to build a system where every operating theater in every region delivers a safe, intelligent, and dignified care. Naamini ya kwamba kuna wengine mmechanganyikiwa na presentation yangu, ndio, it's possible. Ila naamini wengine hamjachanganyikiwa, ila naamini pia kuna wengine mna maswali. Na acha nikwambie maswali makuu mawili ambayo ninahisi wewe mwenyewe unalo. Swali la kwanza, unaamini ya kwamba AI itakuja kumreplace an anesthetist? Naomba nikutoe shaka ya kwamba it never indeed doesn't. AI does not replace any clinician, but rather AI, it enhances the decision making. Kwa makini na uelewe kabisa, AI haiko kumreplace any clinician, and it can never, but AI iko tu pale kusaidia ku-enhance the decision making. Kwa hiyo lazima tukae with composure. Tunasema composure. Just sit, you chill and relax, that nothing can replace you. It's just there to enhance and to make your decision wisely and faster. Kwa sababu tumesema among the most challenge, it's timing, so as you can save life. Kwa hiyo AI inakuja pale na kuboost ya kwamba let's do this fast, let's do this quick, then again you integrate with your own brain, you recall and recharge. By saying that, kuna wengine pia mnajiuliza, is this realistic in low resource setting like ours? Kuna wale ambao tumesema ni wa vijijini, mnajiuliza patatosha, patafaa. Let me tell you, nikutoe shaka. We will be starting with scalable solution. Ninaposema scalable solution, wengine mmeshasema kwamba hamjui kutumia smartphone, you don't know how to use a computer, you have never used a computer, you have never used even any technological thing. But that's okay. Yes, uko kule kijijini, ndio, it's okay. The thing that you only have to know, scalable solution, and there is where tutaanza basic digital monitoring training. Kwa tutaanza kuwafanyia training za zile basic kabisa za digital training, ya kwamba basi kuwasha kompyuta ni hivi, kuizima ni hivi, kufanya hichi ni vile, ili isaidie. Lakini pia kutakuwa kuna phase implementation. Zaidi ya yote, you have to know transformation does not require perfection. Ndio, Tanzania ina evolve, it's transforming. You have to know it will never require perfection, but transformation is a progress. By saying so, I just want to conclude na kusema, when a patient cannot speak, technology must speak for them. The future of a safe surgery is not tomorrow, it's a decision we make today. Thank you all for listening. You was with me, Angel Nanyaro. Thank you.
makofi mengi sana kwa.
Asante sana kwa washiriki wazuri. Jamani, ni wangapi tunazima alamu kule kwetu? Ikilia tu nywa. Wangapi? Ndio AI zenyewe zile. Tunasema tuumiza kichwa hizo sio? Haya, wangapi tunatoa dawa za GA? Si wote sio? Je, are we able to know the entropy that we are giving? Ni wangapi tuna modules za kutuonyesha zile neuromuscular blockage kwamba mgonjwa yuko kwenye level fulani ya anesthesia. Tunapompa sedation. Je, tuna vipimo vya kutuonyesha kwamba yuko light, yuko moderate, yuko deep? Au hiyo ni kazi ya watu wa moyo na mwili? No, ni kazi yetu wote, sawa? So we need what we call it an entropy, sawa? Anesthesia has changed. Tusitoe tu dawa kama mazoea. Sasa hii inakujaje? Ndio tunajifunza ili tuone namna gani tunaweza kuhama tuende kwenye modern anesthesia. Kina Dr. Venance pale wana mashine yanapima NMT vizuri, yanakuonyesha kabisa level mgonjwa aliyopo nayo. Ukiuliza pipu ikoje, ukaiuliza spirometry inakupa, si ndio? Fails, sijui nini, madude mengi. Umemsedate mgonjwa, mambo yanaendelea. Basi bila kupoteza muda, leo tuna presenter mwingine akiwa na furaha kabisa mkutana na mwalimu wake hapa. Kwa hiyo ni kukaribisha Malik na Dr. Bukiro atakuwa na furaha kwa sababu kijana wake alimkuza mwenyewe na leo amebahatika kukutana naye kwenye kongamano. Kwa hiyo karibu sana Malik.
Makofi kwake. Au arudi presenter aliyepita.
MC, hemu wasimame kidogo zaidi.
Tusimame basi, tusimame ndugu zangu. Tusimame. Sijui tuwe nyuma ya kiti. Tuwe nyuma ya kiti. Kiti kisogee mbele kidogo. Tuwe nyuma ya kiti kiwe mbele yake, sisi tuwe nyuma yake. Hatuna jimtrei hapa hata mmoja. Twende tukiruke tu. Kidogo.
Wengine wameshiba usiwarushe sana.
Haya, tujinyoshe. Nenda wote kulia. Shoto. Twende nyuma. Twende mbele. Haya, pole tukae.
Tumekubaliana maswali yote tuendelee kuyatunza. Tuendelee kutunza maswali yote. Labda network ya Morena haifanyi kazi, lakini tunajitahidi. IT wa ndani wa Morena na hisi mnatusikia. Tunaomba network ifanye kazi. IT anahusika na network ya Morena. Tunaomba ifanye kazi. Asante. Sasa Malik, karibu kujitambulisha.
kwa siku ya leo kuweza kuwa na nyinyi kwenye kongamano hili la siku tatu. Pia nina furaha kwa sababu mwalimu wangu ama ni HOD wangu ambaye nimekuwa naye for almost 4 years Uganda yupo hapa, so it has been great. Kwa kuendelea na topic yetu hapa, nimekuwa jukumu la kuongozeni katika mada ya teamwork and interprofessional collaboration in surgical team. Kwa sababu sote ni watoa huduma ya ganzi na usingizi na tunadili na wagonjwa in a surgical, so lazima tuwe tuna teamwork na intercollaboration ya professional mbalimbali ambazo tunakuwa nazo. Kwa hiyo napenda kuweza kutoa scenario ambayo iliwahi kutokezea year back, nani mnaweza mkapata kufikiri namna gani labda ingeweza kufanyika, kwa sababu haya yote yanatokezea katika primary health and tunaangalia ni namna gani ambazo ikitokezea scenario kama hiyo ama wakati ilitokezea hiyo scenario uliweza kufanya nini. We have Gravida 2 Para 1 Living 1 with history of severe preeclampsia with uncontrolled blood pressure. BP was, first reading was 220 of 125 and second reading was 210 of 115, and it was planned for emergency C-section, secondary to obstructed labor. I guess everyone knows now what's happening. Because of lack of this and interprofessional collaboration in surgical team, and we had a poor this surgeon falls and the patient crash, and he got a first arrest, second arrest, and third arrest in ICU. It's sad because the mom was died. But if we could have a good teamwork, I guess this could be solved early. As my previous speakers has said, EECC, AI, and others. We could intervene and solve this before the patient crash. So I give you that to keep in your mind and to see what we're going through. So our agenda today, we're going to look on surgical team and why collaboration is matter, communication in OR, barrier and challenges, building high performance team, and key takeaway of this presentation. As I started with previous scenario, the teamwork is collaboration, is a teamwork. It's just collaboration. And this collaboration is supposed to be efforted by specialized medical professional during perioperative period for the sake of safe surgery, safe anesthesia, and make a patient to be in a safe state. So, as we see, surgeons always is team leader and primary decision makers. Together with technical experts, because he's the one going to operate, even delegate tasks. But for our side is an anesthetist, anesthesiologist. We take a part of airway sedation, hemodynamic stability, pain management, and critical alert. To refer with previously scenario, if you are an anesthetist in that scenario, you just could do your role. But because there were insufficient communication between team, forcing each other quarrel, chaos matters, and the patient crashed. Also, we have a nurse part of scrub or technical, those dealing with sterilization and others. Circulatory nurse, assistant, or surgical assistant. And everyone has on role during surgical field. So why this is more significant, or why interprofessional collaboration is matter? Because over 70% of surgical adverse effect involve communication failure. As we see, we had communication failure. So, and times 2, lower complication rate in higher performance collaboration team. If we have a good collaboration, it means those unnecessary death, crash, brain injuries, and others, we will sort out. And 35% reducing in ORA teamwork. If we have a structured teamwork, it means those errors we're going to solve. So this we give an impact of effect of collaboration include improve the patient safety and reduce mortality, enhance team morale and reduce burnout, fast OR turnaround, and efficient workflow. Also, we're going to have a better anticipation of surgical complication, stronger accountability and trust between members. So, in following this collaboration, we need and we must follow surgical safety checklists. Let me ask you, how many times did you ever use this chart? How many times? Because every day, every time, we have been called to be in OR. So how many times have you used it? Who have ever used it? Only a few numbers. So we need to use this safe Because of this safe checklist, we need to have also communication in operating team. Here we are. We need to updating ourselves in how we are going to communicate each other as a team. We need to use SBAR framework and how SBAR stands and how it's going to use in our field every day. Not only in anesthesia, but every health professional has to use SBAR framework or SBAR communication by looking on situations, background, assessment, and recommendation. If you need consultation, if you report, if you head over to your colleague, whether you have a disaster or any, you need to leave a shift, you need to use SBAR communication. You need to look at situation, you're starting state current problems in clear, even background. And I will show you the example how you can try to communicate using this SBAR framework. Also, in good communication, we need to have a surgical briefing. How many of you are doing surgical briefing? Okay. This we need to do pre-op, team introduction, anticipating challenging, because you're doing visit, right? So if you are doing visit, it means you see the patient. And these are people or colleagues who didn't review. So if you want to stay as an anesthetist, surgeon, nurse, and give an introduction to a case, how many patients do you have, to look at a specific issue that it might be happening with a difficult intubation or anticipating bleeding, whatever. And this will make it easy for you during surgical field. Whatever you need a blood, you did inform your colleague that you need a blood. What if you anticipate difficult intubation? You didn't even ask for consultation. That I'm going with this case, maybe my Lampard 4